Thank you so much. My name is Engy Habashy. I am the Associate Chief of Surgery and a urologist at the Columbus VA. Today, I would like to talk about a topic that I am very passionate about, if I can get this to work. Sexual violence and sexual trauma. So in my brief talk, I'll try to go over the prevalence of sexual violence in the United States, some of the mental health implications that we should be aware of as sex medicine clinicians, some of the physical manifestations of sexual trauma, as well as some things to keep into consideration when caring for current and former members of the armed forces. I don't have any relevant disclosures. I am too afraid to get into any shenanigans working for the federal government. All right, so the National Intimate Partner and Sexual Violence Survey, the most recent one, showed that 3 in 5 lesbian women, 4 in 5 bisexual women, and half of heterosexual women have experienced some sort of contact sexual violence in their lifetime in the United States. The same survey showed that over half of gay and bisexual men and 1 in 3 heterosexual men also experience contact sexual violence in their lifetime. These statistics are horribly shocking, and they show us that the majority of men and women in the United States experience sexual violence in their lifetime. Systems of oppression like racism, heterosexism, contribute to higher rates of sexual violence. Victims generally report that they knew the person who harmed them, and half of female victims and 1/3 of male victims reported that they first experienced sexual victimization before age 18, regardless of the sexual orientation. So as the victim processes, mind and body processes the devastation of sexual violence and sexual trauma, emotions and behaviors and physical manifestation may appear, disappear, and reappear again. And we as sex medicine clinicians should be aware of these emotions because they will impact the relationship with us. These victims may have a skewed sense of safety. They may perceive things that are safe to be unsafe, that like a physical exam in a doctor's office, which for the general public is no big deal, but these patients may be approached in a trauma-informed fashion. They may have difficulty trusting us as their clinicians. After all, the person who harmed them may have been someone that they trusted and cared about. So it's important to know that these patients have a host of emotional, negative emotions. A meta-analysis of 37 studies of over 3 million participants showed a statistical significant correlation between sexual violence and multiple mental disorders. Those who experience sexual violence are 3 times more likely to be diagnosed with anxiety and an eating disorders. They are twice as likely to be diagnosed with PTSD. They are 16 times more likely to have a sleeping disorders. And they are 4 times more likely to have had a suicide attempt. A history of rape strengthening these correlations. And these correlations and associations persist regardless of the victim's sex or age at the time which the abuse occurred. The physical manifestations are numerous, as you may imagine. They're not limited to this list. They include pain, numbness, self-harm to the body part that was involved in the assault, substance abuse, changes in sexuality, unwanted pregnancies, complications of pregnancies, sexually transmitted infections, sexual dysfunction, dyspareunia, sexual dissatisfaction, as well as increased risk of other chronic medical illnesses like diabetes, hypertension, obesity, and cardiovascular disease. The Department of Defense and the Department of Veteran Affairs have actually done good work in collecting data on the impact of sexual trauma on sexual health. A study published in the International Journal of Sexual Health looking at Operation Iraqi Freedom and Operation Enduring Freedom veterans and looking specifically at their sexual health and comparing those who reported sexual violence to those who did not, the authors saw increased rates of sexually transmitted infections, HPV, genital warts, herpes, HIV, AIDS, syphilis, as well as higher likelihood of reporting sexual pain, desire, and arousal disorders. We also know that the additional burden of mental health disorder compounds the likelihood of being exposed to sexually transmitted infection due to health risk behavior, as well as the pharmaceutical treatment of mental health disorder often compounds the sexual dysfunction disorders as well. As a former Navy medic of over a decade and a VA physician, I have cared for many military sexual trauma victims over the last 20 years. 16% of our armed forces members reported experiencing military sexual trauma during their time in service. Being female, being a sexual minority, or being part of a group of low social or institutional power increases your risk for experiencing sexual trauma in the military. Military sexual trauma shares many commonalities to sexual trauma experienced in other settings, but it also has some unique aspects. Victims are often afraid of reporting their perpetrator for fear of demotions, impact on career, or being assigned to unwanted deployments or work assignments, especially if the perpetrator is a superior ranking officer. They may be afraid to disclose a fear of disruption of the unit cohesion. After all, the military is an environment where you are supposed to inherently trust your comrades with your life to function seamlessly and effectively. Those victims may be forced and obligated to continue to live and work with their perpetrator. For example, if you're on a submarine and you're underwater for 6 months, or you're on an aircraft carrier deployed to the Middle East for 6 months. We also know that military sexual trauma negatively impact the post-military reintegration back into the civilian sector. So all these factors really compound the stress and make the help-seeking effect of military sexual trauma even more difficult. The Department of Defense launched a longitudinal cohort study in 2001 looking at over 250 participants with plans to follow them up to 2068, and they looked at multiple health variables. Data from those studies showed that female military sexual trauma victims are 9 times more likely to experience PTSD in their lifetime. And male military sexual trauma victims are more likely to display severe symptoms of PTSD. Also, studies of Vietnam-era veterans showed prolonged impairment decades after the trauma and increased rates of disability and dysfunction. So what can we do? We have to identify those patients. We have to ask trauma-informed questions. Data shows that doctors are not good at asking questions about sexual health for variable reasons. At the VA, we implemented a universal screening program where every veteran is asked 2 questions to screen him for history of sexual harassment and history of sexual assault. If the screening is positive, the veteran is then connected to a multidisciplinary team that can offer the services that they so rightfully deserve. We have a group of experts from across the enterprise, a couple of hundred of us that meet once a month under the umbrella of SHIP, Sexual Health Interdisciplinary Program. We include physicians, nurse practitioners, physician assistants, psychologists, sex therapists, pharmacists, physical therapists, social workers, the entire gamut of the sexual medicine expert at the VA. We meet once a month. We go through difficult case presentation. We exchange ideas, we exchange resources, and we're able to offer our patients the expertise, even if it's across the country with the advent of telemedicine. Which brings me to my next point, leveraging advances of health technologies. We published a study from the VA in 2021 showing that the implementation of computerized modules in women who reported sexual trauma in the primary care setting showed that those who completed those computerized modules compared to those who were just screened and given a referral were more likely to initiate and utilize mental health services for sexual trauma. So in summary, sexual violence is common. It impacts people of all colors and creeds. It starts early. The clinical presentation can be extremely complex, so multidisciplinary approach, it's the best way to work with these patients, and longitudinal ongoing research should guide our practices to hopefully lessen the negative health, social, and economical consequences of sexual trauma. Thank you so much.